welcome to the green edition of our Spectrum series. This time we are going to be focusing on medical management and how that relates to our spectrum of solutions here at Nova Healthcare. The presenters today are myself, I'm the product manager for Nova, Teresa Vincent. We also have Anita Braun, who is a registered nurse with a bachelor's degree in nursing. She is a certified health and wellness coach, holds an advanced certificate in completion of care management, and an additional certificate in management in nursing. Working as a nurse for more than 30 years, Anita has experience in office-based family medicine, medical surgical settings, and practice transformation in clinical and leadership roles. She has been with Nova since 2017. We also have Maria Borowski, who is a registered nurse with a bachelor's degree in nursing. She is a certified case manager and is also a seasoned utilization review nurse and nurse manager. Maria brings more than 30 years of in-hospital experience to Nova, as well as a depth of case management in both clinical and insurance settings. Maria has been part of Nova's team since 2018. We also have Corinne Gahoda, who is a registered nurse and certified case manager specialized in providing acute and chronic care through direct interaction, case management, and utilization review. Her depth of knowledge and experience includes acute psychiatric and substance abuse care, care coordination and procurement of appropriate services, and an ability to interpret rules and regulations as they apply to nursing and benefit administration. Corinne joined Nova as a case manager in 2016 before transitioning to her current role as our utilization review nurse. She specializes in behavioral health care. And last but not least, we have Nick Young, Nova's Director of Health Plan Performance Management. Nick joined Nova in 2014 and has held positions as a disease manager, clinical quality assurance specialist, and clinical applications administrator. In his current role, Nick is responsible for the research, development, and implementation of initiatives designed to mitigate client cost trends and improve member health outcomes. Nick is also a registered nurse and holds a bachelor's degree in information technology. So that is our all-star crew who's going to be talking to you today about medical management. And Nova is a third-party administrator, but we feel like we do a little bit more than your standard TPA. We were established in Buffalo in 1982. We are a fully owned subsidiary of Independent Health, and our goal is really to manage trend, reduce healthcare spend, and improve health plan performance. So what you're going to hear about today touches on all of those things and how we take a holistic approach to medical management. So first, let me reorient you on the spectrum of health plan performance management opportunities. If you've been with us for the earlier portions of this series, you may be familiar with this, but if this is your first time joining us, the spectrum of solutions comes from this idea of a prism and how it refracts light. So if you begin with the white light source, which is your company profile, whether it's a broker bringing in services, whether it's a client coming to us directly, that's the pure white light that comes into the prism, which is Nova, your TPA partner. And then that refracted light, all those colors of the rainbow, that visible light, that is where we come into the creative solutions. So we go through each of the colors as part of the spectrum, and we go through the different saturations of color within each color itself. So we've already done webinars on network, telehealth, and wellness, and today we're going to focus on medical management. So that's the green band in the spectrum. And medical management at Nova is really about looking at the whole person. It's really taking that approach of not just looking at one particular disease state or one particular risk factor. It's really looking at all the different interlocking pieces that go into whole health. Obviously we look at individuals, not just cases, not just individual problems that come up, but we want each individual person who is part of the Nova family to be as healthy as they can possibly be. So if you think about medical management on that spectrum and the different saturations of color, we do have the very traditional solutions within medical management. That's the idea of pre-certification, case management, disease management, all of those really foundational things that we do and that you would expect to get out of any plan that's doing medical management. We are going to add on to some of our creative solutions, some of our customized strategies to provide solutions around specific disease, utilization, or risk stratification needs. That's really where Nova excels in the spectrum, is that sort of middle saturation. And there is also opportunity for expanded solutions for care, which Nova doesn't really do so much at the moment, but that would include options for medical tourism, shared savings, and using, say, lower cost alternative locations. So that's the full scope of services under medical management. And now we're going to move into a panel discussion, go into some of the more specific questions around that, so you can hear from our experts on the call about how we manage this in the real world. So it's great to talk about the numbers and the data and the philosophies behind it, but we're going to talk about how it actually works in practice. So case management has evolved quite a bit over the last decade or so, and there have been a lot of shifts in care transitions, and that was really where we wanted to start. So, you know, Maria, you have really been at the forefront of this for a lot of your career, so we thought we would start with you and ask if you could discuss the shifts in case management over the past decade.
Yes, thank you. I would love to do that. And case management has been an evolving role in the industry to meet the member and client need among the changing healthcare arena. In the past, we were in what you might call reactive mode, calling out to those members who were very ill to provide education, resources, and navigation for their healthcare to assist with their recovery and treatment. The trend of case management has been changing to assist our members to be proactive about their health prior to any catastrophic conditions occurring. Our analytics team can now identify our rising risk members. We are able to call out to assess these members for any opportunities or gaps in their health care and work with them to diminish the possibility of that catastrophic outcome. Another avenue for outreach has been to those members who have participated in biometric screening events organized by their employers. Once again, our analytics team can take the data provided from those events and identify our members who may be at risk for adverse health conditions. Our assessment outreaches include utilizing the social determinants of health so we can better identify potential gaps in care that may exist in our diverse population based on their social conditions. During these outreach calls, we also review a list of preventive measures such as mammography, colon screenings, and age-appropriate vaccines to urge our members to remain proactive with regard to their health care, to take steps for the prevention of disease as opposed to disease treatment. One example of an outreach comes to mind regarding a member who was identified as a rising risk. During my outreach assessment call, we reviewed the list of preventives. She had not yet completed her yearly mammogram. It was overdue. We discussed the importance of regular screenings on that call. 2 months later, the member repopulated for another call, this time triggered by a breast cancer diagnosis. When we reconnected, this member was extremely grateful for my previous outreach. She stated she made her appointment for the mammogram shortly after our initial call. She was diagnosed with stage 1 breast cancer and needed only minimal surgery and treatment. Had she waited for that mammogram screening, there could have been a very different outcome. As healthcare trends continue to evolve, case management roles will also need to align with those changing trends to promote quality, cost-effective member outcomes driven by evidence-based practice. Thank you.
Thank you, Maria. That's a great real-life example of how you can really use case management to prevent or catch things when they're early on. So the way we've talked about case management over the last decade or so, it really turns out to be the tip of the iceberg, and you really need to go underneath the surface so that you can really access that whole person model of care and look not just at what's going on now, but what could be going on in the future and where we have gaps to fill. So Nick, I would like to turn it over to you to talk about some of the data points that you knit together to reach these outcomes.
Yeah, so Maria touched on it very well in that we look at rising risk for a member. So traditionally what's been done through case management, at least as far as my experience has gone, is that we're very easily able to identify members with catastrophic conditions that are ongoing right now. But what our approach was is let's take a look at their risk score over members' risk score over time. We do use some different risk scoring models, and we'll look at that and say, okay, when we see some incremental changes of a certain amount, let's trigger them for outreach because they're obviously at this point heading towards a direction where their risk is increasing, and we would like to intervene before they get to that catastrophic phase. So that's kind of what Maria had just described with the member where she had that positive outcome. Not every time are we going to have that momentous occasion that Maria landed on there, but that's what we're aiming for. We're aiming to get those members and serve them up prior to being catastrophic, and we do that through, like I said, through an analytics process where we're evaluating the different claims data, utilization data patterns that the member has, and applying different risk scoring models to that.
And taking a really proactive approach to connecting all the different pieces of healthcare. So, Corinne, this next question is for you about looking at that idea of whole person care. You are our expert on the call on behavioral health, which of course mental health is health and is as intimately connected to any physical health that we've ever talked about. So could you talk a little bit about the value of integrating behavioral health to achieve that idea of whole person care?
Yeah, so first we look at how our behavioral health cases received, and that's through several different ways. UR requests for services that require pre-authorization or RN review, so mostly behavioral health related. Sometimes we find behavioral health related needs are identified in medical cases. When this occurs, the case is sent to a behavioral health case manager for further review and outreach for assessment. The medical case managers may identify in their review that there is a behavioral health need that requires further assessment in addition to their original medical diagnosis. An example that commonly is identified, we'll see anxiety and depression associated with chronic illness or in the early days following, for example, a cancer diagnosis. The member may need help finding a provider, discussing medication options, building coping skills, or finding community resources to support their mental health while undergoing treatments. The behavioral health case manager outreaches as an additional resource or as a consult to the medical case manager. The behavioral health case manager will outreach and provide specialized behavioral health assessments, links, and education. Then the case goes back to the medical case manager for continued follow-up, and the behavioral health case manager will remain available if needed. All the behavioral health resources and documentation are available for the medical case manager to review again if needed. We also get behavioral health ER outreaches that are sent to the nurse when a member presents to an ER with a behavioral health diagnosis, which also includes substance abuse issues. The behavioral health case manager ensures that the member has an outpatient provider, medications if needed. The behavioral health case manager also ensures that the patient is safe both mentally and physically. We make sure the member has their local crisis services contact, a safety plan, support systems, safe housing, as we do with all of our member outreaches. Additional ways to provide behavioral health support is also through utilization review. We ensure that each patient has appropriate follow-up with the in-network provider. The reviewing nurse can outreach to the treating facilities and provide direction regarding prior auth needs or network steerage if it's required. We provide case management referrals at discharge, or if while reviewing we see an indication of a possible behavioral health need or even a medical need. Regardless of the referral source, utilization review, behavioral health case management, and medical case management work together daily in a collaborative way. Thank you.
Thank you. And Nick, can you walk us through how that looks from the data perspective?
Right, as mentioned before, Teresa, we look at a lot of the different claims data sources available to us to include facility claims from hospitalizations or ER visits, claims, professional claims from office visits, as well as RX or prescription data as well that indicates and identifies members as potentially having a particular condition. So with that, we're able to identify members that have a probability of having a mental health condition that would benefit from support from our team here. To your point earlier, it's not health is behavioral health, health is physical health. It's all health, and we work together to collaborate on that. One of the ways that we're able to do that very well is through our ER outreach program, where we're looking at the ER claims that come in, where members start to use the ER as their primary source of treatment. because they're not being properly managed or because that's the only resource they see available to them. So as we identify these members and serve them up to our behavioral health case managers such as Corinne, they're now able to take that and say, okay, we've identified this member is now utilizing the ER to manage their behavioral health condition. And, Corinne would be able to work with that member to help, collaborate and get them to the correct provider. We've had arrangements with various clients of ours where we've actually taken that, we've looked at getting the member to an outpatient office visit within a very short time frame after discharge from an inpatient facility as well. And that's something that was very successful as well, because one of the points out there is that the early intervention with the primary care provider after discharge will help decrease the rates of admission going forward. So anytime that we can work with them, and that's a benefit of us also performing a lot of the utilization review services for many of our clients as well, that we're able to see that the member is going inpatient for a behavioral health need, or that they're having different behavioral health services being rendered that we're reviewing, and because of that documentation, which is actually done in the same system, so we're seeing our utilization management team and our case management team both documenting out of the same system, which provides that visibility of what that member is truly going through from that utilization and claim standpoint.
Right, so because we really look at that whole person approach, we're not segmenting our data so that there's limited visibility. We're really cross-pollinating across the different areas so that we can catch all of those things. So we're looking at gaps in care, we're looking at gaps in access, and we're really helping the individuals figure out how to connect the dots so they can actually get to the best possible care, regardless of what is going on with them. And I do think that is one of our major differentiators in medical management, and how we go a little bit deeper than what people think of as traditional medical management. We also, of course, are heavily focused on positive health outcomes. Anita, I know in your role as a coach, that is really central to what you do. So can you talk a little bit about how we create those positive health outcomes for our clients and their members?
Yes, thank you, Teresa. As nurse case managers, we look at the member as a whole and address the medical, physical, emotional, financial, psychosocial, behavioral, and other needs of that member. And we first start with creating relationships. And through this relationship, we utilize motivational interviewing to identify needs and help them create short and long-term goals to work toward a healthier lifestyle. This includes the case manager acting as a liaison between the members, their caregivers, providers, and payers, as well as providing education to the member on their disease state to help them better understand what they need to do for self-management of their condition and to prevent risk factors such as heart attacks, strokes, or events that could require emergency room visits, hospitalizations, or worse due to their condition. And often we see members may not have been educated or did not hear what was told to them by their providers. So we're able to provide that educational piece and answer questions about their disease state they may not have asked or understood. And we ensure that the member has the tools they need to manage their condition. Whether it be, do they have a glucometer? Do they know how to use it? Would they benefit from a continuous glucose meter? Do they have their medication and are they taking them as prescribed? We may also provide them tools such as apps that can assist with meal planning or resources to better manage their condition and needs. Medications can be very expensive, and we often find members may not be taking the medication as prescribed because maybe they can't afford it or experience side effects and stop taking it. This can have a negative effect on the control of the member's condition. And often members may be experiencing increased stress or anxiety or depression, which can cause negative effects on that condition and can lead to possibly elevated blood glucose levels, elevated blood pressures, or unexplained illness. And this can often lead to that domino effect of decreased daily productivity and absenteeism. And as case managers, we work with those members to make sure that they're getting the care, treatment, and resources they need to help improve their overall health and meet their needs. Thank you.
Thank you, Anita. Yeah, you mentioned absenteeism, which is a big issue. I know we've also had discussions in the office about the problem of presenteeism, of when someone is still showing up at work, but maybe they're not functioning as well as they could be because of different health issues that are going on. So those are both really important things to consider. And Nick, you have this slide here that you can walk us through about how we really take all that data and how we really make it personal to improve health outcomes in high-risk situations. So if you could just walk us through the data on this slide, that would be great.
Absolutely. So looking at this slide here, what we're viewing here is admissions that we have a discharge to a home or home-like setting. So the member's gone inpatient, and now we're at home, and now we have various needs that are likely different than when we went into the hospital. To the point that the team has made is that they may have a lot of different questions as they get discharged. Something new has changed in my medication, or I need to change a dressing on a wound or something like that, and I don't quite remember the details on that. So the goal, we have a program where we do this outreach after a member gets discharged at home, and we kind of track that through the 7-day, 14-day, 30-day readmission cycle. And so we've compared this, and we've identified that those members that participate in our post-call program, our transitions of care program, where we make an outreach to the member, we see that the 30-day admission rate when intervention has been had is 4.5% compared to almost 10% of the members have a 30-day readmission when they don't participate within our program. So there's an incredible difference. Now, again, that can be a causation or correlation, that can be debated, but there's definitely a clear correlation between those two activities there. With that, and we have some savings associated with that as well. And what we did is we took the average cost of a hospital stay being approximately $20,000, and then applied the probability of 30-day readmission, which is roughly 13 to 14% based off of some HCUP data that we have available to us. So we took that and we applied that 13% times the total admission cost times the total discharges home, and that's where we arrived with that 289,000 of averted admission savings. That 384,000 of potential admission savings would be if we got every member to enroll and engage within this program. That would be the optimal potential savings of that 30-day readmission. So this is one very concrete way where we can show our value to our clients from a financial perspective, but even beyond that, to the point of Anita, with regards to presenteeism and absenteeism, there's a piece that goes along with that as well. If we're able to assist the member, maybe they don't have a 30-day readmission, maybe they're able to go back to work, but they may also now, because of participating in our program, have a better handle on how they should be taking their medications so that they're able to function to their optimal capability.
Right, anyone who's ever experienced hospitalization or been a caregiver of somebody who's experienced this, you know how hard it is in those first few days after when you're adjusting to all the different components of it. And the logic behind this predictive modeling and how we project out the savings, I think that's really helpful, because it's poorly understood if you're just looking at numbers on a page, what your actual return on investment is for some of these programs that we have. So we really do try to dig in and look at the humans behind the numbers. So, Nick, I know this is part of your philosophy for sure, and definitely all the case managers. Every single one of those percentages that we increase where we're preventing people from readmissions, that's not just dollars that you're potentially saving, that's a quality of life that is improved for somebody that is going through a health crisis. So I know that's one thing that we philosophically adhere to very closely, and that's why our work is so meaningful and in-depth on these topics. We did also ask, as this is a pre-recorded webinar, we did ask anyone who signed up to receive this recording if there were any questions that they would like me to ask the panel. We did have one question that came in, and that question is, are you utilizing one electronic system for tracking? So I'm going to throw that open to the panel, though I think that's probably more of a Nick question than for everyone else. If you could talk a little bit about our electronic systems.
So I'm not exactly 100% clear on what is meant by tracking. So I'll give a general overview as to how things kind of work as far as how we get the data, how the staff and how the nurses see the data, and how we utilize that data on the back end. So on the back end, we have a number of different data sources that we'll use. We'll use the medical claims, we'll use RX claims, any potential lab data that we might get. Maria had mentioned earlier that we'll have different health and wellness programs that might be implemented by some of the employer groups that we help serve, and we may have the ability to receive that data back. So we will store that data in different databases and utilize that from a referral source perspective. So, we do have databases for that. From the user end, from the nurse's view, we have a system that has visible to them and case management data, as well as an analytics view of everything that's going on. So they're able to view gaps in care and medications. It's, the tool that we use has some visualizations that makes it easy for the staff to view, okay, this member should be taking their diabetic medication, but we see a gap of like maybe 2-3 months of them not getting it. That would be an indication, hey, maybe this member needs some assistance in getting that medication. Maybe they forgot to get it refilled. So they do have that view in front of them as well. And then beyond that, all of their documentation, the case management documentation, utilization documentation, all of that is also done in that one system as well. So a lot of things are being done, at least from a visibility standpoint, within one system. And then everything from that system is also reportable as well.
So a lot of integrations, a lot of visibility, and a lot of shared information, not people hoarding information in their little pockets of the company, but really an ecosystem to make sure that we're managing everybody's health appropriately. Okay, well, thank you for attending our medical management webinar. This was, as I said, the green band in the spectrum. Next up, we are shifting over into blue, which is going to be pharmacy management. So look for that webinar coming in December of 2021. If you follow us on LinkedIn, you'll be one of the first to know when that webinar is coming out. Thank you for joining us today. And if you have any questions, please feel free to reach out to the team at NOVA. We would be happy to help. Thanks.